So I'm joined today by Dr. Melanie Gunawardene from Hamburg. Thank you for coming to talk with me. We're going to talk about FARAPULSE, amongst other things. Can you just tell me a bit about yourself, first of all?
Yes, thank you very much. Thanks for having me. So I'm Melanie Gunawardene and I'm a cardiac electrophysiologist at St. George in Hamburg. It's a big high volume center and we perform about 2,000 to 2,500 ablations a year, and I would say most of them are atrial fibrillation cases. So a lot of work to do in Hamburg. Yeah.
Sounds great. So you've been using FARAPULSE?
Yes.
And can you just tell me about your first experiences with that?
Yeah, sure.
How it's gone?
So we were lucky and we got the system very early. So we started in March 2021. So we already have a 2 years experience, and we started right away with integration into mapping with the arrhythmia system and the first cases, because we wanted to assess the lesions that we create with PFA, because we knew it was just a fluoroscopy-based system and we didn't know much about it. There was some first-in-human trials, but at this point there was no real-world data. So we tried to make an effort and create some data that we're also lucky to publish, and saw that PFA creates wide antral lesions when you combine it with ultra-high density mapping and visualized catheter in the system. Yeah.
So you've got a lot of experience early on, you've got your own data, you've seen the manifest data that's just beginning to come through or has come through. What are your thoughts about that?
Yeah, I think it's a great effort, first of all, and we were also lucky to participate in that. And I think it's really brave to bring out this data so early after the release of such a new technology, because you don't know what the results are going to be. So you kind of have a risk when you put together a data set like this. And I think it's a really good safety profile. When you look at non-thermal energy source, there's no relation adverse events to the PFA system that is like systematically seen, which is very nice. I think there are some issues maybe that need to be addressed, because there were really experienced centers in regards, for example, to cardiac tamponates, but changes have been made with the wire that has been used. But the outcome that has been presented yesterday at the late breaker after just 12 months showed that no matter if you perform less than 50 procedures or more than 100, outcome wasn't different and was overall almost 80%. So I think that is, for this really young and new technology and such a real world scenario where everybody was able to participate, really strong effort.
Great comments. How do you think PFA is changing your practice?
That's a good question. Thank you for that. So I really enjoy the procedure, and I think it depends on what you want to do. So it is a strong tool to perform a fast and predictable PVI. So for a first ablation procedure, the lab efficiency is very fast. You can do it within like a little bit over 30 minutes and you are done. And you have probably a high durability on the lesions you've created, as we have just learned from the manifest data yesterday. On the other side, we are also focusing in regards of clinical studies that are off-label use of the catheter into more complex cases like persistent atrial reduce or also in atrial tachycardias. And I think this is a very interesting field, because those are patients who have failed thermal energy sources. And now they're coming back with the recurrence of arrhythmias, and we need to treat them and we need to offer them something. And so this might be an option, for patients who have failed prior therapy, to create a durable lesion and maybe address more substrate.
Understood. So clearly that's something that Boston can't support at the moment, because it is off-label use, but very interesting to hear of your clinical experience and an area to focus on for future research, I think. So I hear very strongly about predictability and safety. What do you think about effectiveness compared to your previous experience with thermal technologies?
So just from our point of view, from the patients we have treated, we have performed 7 redos and only 1 pulmonary vein was reconnected. So from that point of view, it's a really high PVI durability rate, and also what has been reported. And also yesterday in Manifest, it was seen that centers that had a PVI durability of over 50% performed better in the outcome. So we have the correlation that proof of concept, PVI, durable PVI leads to better outcome, and that we now have a tool where we might achieve it. I think we're still in the learning curve, so this might be also something we need to address. And also in the long term, I don't know how many patients we can treat with only PVI, and this is something we will see in the future, which patients will come back with durable isolated veins but still have arrhythmias, and where are they coming from? It's still going to be a subset of patients, I'm sure, but I think we're getting better and better creating durable lesions.
Very interesting. Where do you think rhythmia has a role in this thing?
So for me personally, as I said, in the studies and like off-label use of I see it in the complex cases, but also when you just perform PVI and you start with it. That's why I started this with our conversation, that in the beginning, when you only use fluoroscopy, there's not so much information because you don't have dye, it's not a balloon technology. So how do you know where you are and what you are doing?
Got it.
And when you integrate it into 3D mapping, then you can actually see where you position it at the PV ostium. And the system, we've learned this, there has been some reporting of unintentional posterior wall isolation, but when you integrate it with mapping, you can see that you can move the catheter anteriorly and you avoid this completely.
So do you think the use of rhythmia is an adjunct to learning, or is it a fundamental part of the procedure? Where does it kind of sit for you?
If you haven't done it before, I would definitely say it is a good feature for the learning curve. The next thing that where I really see it, especially with the system moving forward and the 3D integration that is coming, is that you will need less fluoroscopy. And I think this is a very strong argument for 3D mapping. And then also further down the road in the complex cases, because the rhythmia system provides this mini basket catheter for mapping that includes 64 electrodes, and you can depict a lot of signals, and you can perform 3D mapping in really complex arrhythmias. So the combination of really good ultra high density mapping to figure out complex arrhythmia substrate or mechanisms in combination with a very effective tool to create a lesion is something where I also really see the technology going.
Understood. I think that you've been involved with our R&D team looking at some further post-processing analysis of rhythmia data. Can you just give me a quick insight into that?
Yes, sure. So the catheter in the future will be integrated into the 3D mapping, and it will give you not only the anatomy but also an idea of where the lesion is going to end up, how the electrical field is distributed, and it will be easier to see which spline is doing what. So at the moment in fluoroscopy, you can't see which spline is at which position, and this problem will be solved with the integration.
Great stuff, great stuff. We had a really good conversation around the clinical aspects and the usability and the outcomes. What about patient experience? Any observations on that compared to thermal technologies?
Yeah, so we are also really participating in the German Heart Foundation. So we write a lot of articles for patients that are not scientific articles as you would publish in a journal, but they are about different energy sources and the profile, the efficacy and the safety. And the patients read it and they call up the hospital because they want something that is safe to the esophagus. They see that they can avoid a complication. So we have a lot of patients who come to us just by having knowledge about what they are finding on the technology themselves, and they really demand to have PFA. So I think this is also something that we need to consider when this catheter is not only something for us doctors to choose an energy source, but now patients also start to choose, and they clearly like the fact that it's safe to their esophagus.
Fantastic. Melanie, that's been a great conversation. Lots of really interesting observations. I've got a really good understanding now into how you have been using PFA in your clinical practice and the advantages that you see. And thank you very much for the contributions that you're making to the literature and to the understanding.
Thank you very
much.
much.
Great talking to you.
Thank you.